2, the area of a subject of interest is increasing because it increased from 41% to 444, and which is because we are dealing with the subject which needs have more impact on the fertility, and the clinicians such as ours are going to have a more inclination towards the research and towards the publications in the same subject. We know why to blame me is a predictive sentence when we talking about the oocyte which has been retrieved and which is going to go into the blastocyst formation. But there are the certain things which not widely accepted. The oocyte quality is the major factors for every of the patient, because the oocyte is the larger cell, and this larger cell has an impact of formation of the embryos and formation of the good blastocyst. Is the oocyte quality is affected in endometriosis? This is a review literature in 2017 will tell you really it is an impact of a oocyte quality or not. Let's see what is the largest cell in the human body is the oocyte. The good mature oocyte, what needs to have a good mitochondrial amount and the mitochondrial DNA, and also the good environment for steroidogenesis assisted by the granulosa cell and 50 aromatase activity. Because there is a protection from the oxidative stress, and if you have this mitochondrial amount and the mitochondrial DNA which is on the higher side, we are going to know that there is a protection from the oxidative stress by the brain neurotrophic factors, and lastly the spindle apparatus. If all these things is going to be a good, we know the formation of the good embryos will be there, and the blast is going to be excellent. Then why we need a mitochondria? Because if you're thinking that the cell which is the highest in his potential is the oocyte, and in oocyte what is important is the number of mitochondria and the DNA. The mitochondria are the double membrane organelle, and it is a diverse signaling pathways between the intercellular process, and this is responsible for the aging control as well as the control of the apoptosis. Mitochondria is hypothesized to be derived extensively from the oocytes and may be essential for the oocyte maturation, and the mitochondrial abnormalities and the dysfunctions could have the adverse influence on the human embryonic development and might affect the competence for fertilization. When you are thinking of the number of the oocyte being retrieved and number of formation of the embryos, this particular sentence make an impact that if the mitochondrial content is normal, then the chances of fertilization and ongoing fertilization process is a healthy one. In the endometriosis, the number and the size, the structure, mass of the mitochondria is less, and that affects adversely the oocyte maturation as well as the fertilization. If you see, you are going to get retrieval from the endometriosis patient where there is an endometrioma. There is a definitely your embryologist will vouch that there is a definitely a not good looking oocyte are being found, and this is because of the abnormalities in the mitochondria, which may be a swollen or maybe a blur, or maybe there is a vacuoles in the mitochondria. Saying so, if we need to have a low DNA content, it mainly affects the oogenesis, and that will responsible for the maturation of the oocytes, and the poor energy production could lead to insufficient mitochondrial biogenesis and oocyte maturation. The functions I already talked about, because mitochondrial content and the powerhouse of that is a DNA. If that is on a good side, we are going to retrieve more M2 oocytes, and we are going to have a more chances of formation of embryos and the blast. And usually in endometriosis, this is going to get affected, and we are not going to have that particular good site of the blastocyst to implant. The DNA is decreased in endometriosis. We know the oocytes is a different fate. These are the spindle letters. Again, from the DNA content, you must understand what is mitochondrial mass. Then after the mitochondrial mass, nowadays we are very much goes into the spindle view while doing the EC. If the spindle apparatus is abnormal, or there is a structural component of the alpha and beta tubulin subunits, in a normal things, it is a compact and made up of a distinct spindles. But if there is a dysfunction in this particular spindle, which results into abnormal chromosome alignment and the fertilization, and that will be responsible for for arrest of the growth and the formation of the embryos in later teens. The abnormal stereogenesis lead to a low E2 levels and altered post-ovulatory surge of progesterone secretions. And when you are talking about P450 aromatase activity, the key enzyme of the estrogen production, which is a P450. And what all these things is related to, because we know that if the M2 oocytes are less, if your E2 levels, if you compare the E2 level in the endometriosis patient as compared to that of the normal, you will yourself will understood that the E2 levels are less, and will again has a post ovulatory surge of this progesterone is not been there. So IUI cycle results, even if the reserve is good and you are doing the IUI in endometriosis patient, the results are low as compared to the normal patients. The ovarian endometriosis and endometriosis at the other pelvic sites may have a detrimental effect on the steroidogenesis by decreasing the expression of the P450 aromatase enzymes, and that has been documented in recent years. What is the oxidative? Why we need to talk about oxidative stress? Because it has the effect. Recently, it has been seen that there has been increase in oxidative stress in the follicular fluid near to the ovarian endometrioma by using a proteomics by the mass spectrometry. And if you have the oxidative stress which is on the higher side, you will definitely understand that we are giving antioxidants in some of the patients. This why we are when wanted to give these patients antioxidant, because we wanted to increase the yield of the M2 oocytes and the healthy oocytes. Again, we come down to the last part of it is a brain derived the neurotrophic factors. This is a basically have a gene which is found in a specific polymorphism. If you're thinking that you are using some protocol which is using only the FSH, you may not be knowing there is a FSH polymorphism or LH receptor polymorphism, and that could be the one of the reasons your optimum response will not be there, and you will not going to get a good number of the oocytes, and that's why the impact of the endometriosis is going to have as far as the endometriosis is considered. There are significant fewer meta-2 oocytes retrieved, which I already talked about. Why? So I already talked about because there is a low mitochondrial component in the oocyte. There is low DNA saturations. And similarly, your P450 activities of the aromatase activities, which is on lower side, and which leads into the abnormal oocytes or maybe oocytes with the poor fertilization capacity. This is the clinical significance which has been quoted in 2021. If you see the number of oocytes retrieved in the patients with the endometriosis is less, number of M2 oocytes retrieved is also less. Mature oocytes are going to be a significantly a statistical significance. Mature number of oocytes per number of oocytes retrieved is less. All of this we know. What we don't understand that these are the disease which is going to affect the fertility potential, and that's why nowadays we have the strategy to get more and more eggs and doing a preservation of the embryos and doing the later on embryo transfers in those patients. The abnormal shape of the oocytes, if you see, this is the control where 1.9 and the 6%, and that is the significance when you are doing the we call as home pickup. You will understand while doing the home pickup, some of the oocytes is abnormal in shape. This abnormality usually or profoundly found in the patient with the endometriosis, and you can see that the endometriosis has its impact. We can think of the change, the history of the endometriosis surgery impact the results, added the number of. So we need to understand those are patients with the deep pelvic endometriosis going for the operative, and this really are going to be a beneficial because we know nowadays everyone is doing a some of kind of the surgeries and going to have a excellent surgical skills. Our India has good surgeons, endoscopic surgeon, and I must acknowledge their efforts because they are literally going beyond their boundaries of handling the bowel, ureters, and everything where the endometriosis is going to affect. But you need to understand whether you are going to do the surgery and without going to do surgery, whether it is going to impact the number of oocytes. What we because this is related to the fertility issue. This is not related to the surgical management for the pain of the endometriosis or recurrent endometriosis. I'm talking about the fertility potential of patients. And this is going to be definitely, if you're thinking that there's a significantly number of oocytes which has been retrieved. Total number of oocytes is going to get retrieved is the same. So the surgery per se will not going to have an impact on this. No medical or the surgical technique. There is a randomized RCTs tested on 3 months of GNH analog treatment prior to the IVF, looking for the number of M2 retrieved and the main outcome. The significant higher fertilization rates is seen in FOGSI as compared to the IVF. That has been statistically significant. But if you're talking about change in a protocol or change in giving a GNH analog 3 months prior to the stimulation, it is not going to increase the number of yield of the M2, and that's not going to give you something better. If you wish to have a better outcome, go for the stimulation again and again. Go for FOGSI and go for the cryopreservation and the going to get transfer in the subsequent cycles. Regarding the where I should be operating the patients and going for the stimulation, that is not significantly going to get significant benefit out of it. But definitely, if the anatomy is distorted and we are not going to go for the oocyte retrieval, in those situations, the surgery prior to the stimulation may play a role. Otherwise, significant statistical significance is not been documented anywhere in the part of the world. The absence of pre-stimulation treatment was associated with significant higher number of maturation oocytes, and that's why, my friends, when I talk about taking of GNR analog, you should not be talking like that. I will give a GNR analog or maybe a diagnosis prior to the stimulation, which will not increase your number of oocytes yield. The good oocytes, the endometriosis, you can see here the total number of daily agonist protocol and delayed agonist protocol and antac protocol. If you are seeing number of oocyte retrieved is the same, number of M2 oocytes remains the same. So what cumulative success in the pregnancy remains the same. So whatever protocol you like to use in the endometriosis is okay, which will not going to increase the number of oocytes and number of maturation of the oocytes also. The drugs makes a role, whether I should use a FSH or whether I should use a HMG. You can see this, the recombinant FSH and HMG. If you use a recombinant FSH, the chances of retrieval is statistically significant as compared to that of the HMG used. But mind well, it depends upon the number of cycles he is undergoing and number of economical point of view as far as the patient is considered. The further research and further scenarios, the infertility endometriosis patients could not be related to the endometrial environment and diminished oocyte quality. There is a randomized studies where there is a patient of endometriosis and with the donor cycles IVF. It clearly indicates that if the donor cycles IVF is been done in a patient with the endometriosis, showing that there is a higher significance of the take-home baby rate, and that indirectly suggests that there is a definitely oocyte which is going to have some problems with the endometriosis. We're going to solve this problems of the oocytes by giving antioxidants or maybe giving a different protocols of stimulations or maybe a stimulations and taking care of the oocytes and the embryo formations prior to going for the surgery. We definitely know a share oocyte programs which showed the same success rate, and that will definitely will alarming us that even if you are going for the donor cycles, definitely endometrium is not going to get affected. Can the fate be been changed by giving early treatment? See, you need to diagnose the patient first. Diagnosis is more important. What is the stage of the disease? That is important. What is the ovarian reserve which is left out with the patient? That is important. So, AFC and AMH, that will be a predictive factors for decision making. Ovarian cortex biopsies from the ovaries with the endometrioma. You can definitely have a in vitro maturations technique which is coming now. With these patients of decreased image and AFC, definitely regenerative medicines plays an important role, but that has to be taken with a pinch of salt. Shows us what I feel by it, that whenever you are dealing with the patients of the endometriosis and the oocytes, these are the analysis of 13 of randomized sample size of the donor oocyte recipient autologous IVF cycles, which will tell you that definitely these are patients which is going to give a higher impact. So, saying that, what is the take-home message as far as the take-home message is considered, is quality of the oocytes has a fate on the implantation fertilization. Definitely, the quality of the oocyte plays an important role. Endometriosis is definitely going to affect some part of the oocyte quality. We may not be knowing exact and where is going to get affected. Definitely, there is a strategy to go with it. We need to understand there are different things. You can give antioxidants, you can give agonist protocols or maybe antagonist protocol in some set of patients with the pre-treatment, and definitely will can change a little bit fit of the patients in endometriosis. Surgery is not first taking point. It depends upon the stage of the disease. And if you are dealing with the DI, definitely after the oocyte retrievals and the fertility potential has been documented, you can go with the surgery for the DI. And I'm really thankful to again Sejal for inviting me, and I wish her for elections to come. I know she's going to come up with a green color in the elections too. Thank you very much.
Thank you so much, Ashir, for being here, and you always support me and motivate me. Thank you so much. And we are like now family over a period of years, and it was a wonderful talk. I request chairpersons to kindly give their concluding remarks. Thank you,
Always
Madhulika ma'am.
congratulations and appreciations to all of you for such a wonderful arranging of webinar. And thank you, Dr. Ashish. And you have made everything very clear and in a very short time.
Thank you.
And such a lucid presentation. I must congratulate you.
Thank you, madam. Thank you very much.
Very
Dr.
simple
Sikha.
explaining. Yes, ma'am. A very simple explaining of the basic facts, and obviously giving us the tips and points that it's not surgery, because it's the oocyte quality and the live birth rate are very similar in oocyte donation program. Everything was wonderful, sir. You explained the topic very nicely and very loosely. Thank you so much for that.
Thank you. Thank you very much.
It's always good to see and listen for a topic like this from you, sir. Thank you so much, sir.
Thank you. Thank you.
We can encourage any viewers that questions on the chat box, and coordinators can ask those questions if there are any. So we can move ahead.
I would like to ask a question if permitted.
Yes, please, ma'am, go ahead.
Sir, would you recommend like in DIE or something like that uh, if the patient is suffering and
Dr. Ashish.
Yeah.
like you said, surgery is not the first step we go for that, but like patient is symptomatic, she's having DIE, so should at that time surgery be considered first, because she's already suffering, and then she's having fertility issues also, like, or should we start away begin with
There
other
are
infertility?
two things about the
Sorry, sir?
DIA and the infertility. If the DIA is there and your ovarian reserve is less, it is better to stimulate the patient and make the embryos full, bank full with the embryos,
Yeah,
and then
that's true.
do the completion of the surgery.
So there is a role
Because
there.
once
We can preserve them. Okay, sir.
yes,
That's what the next question. Thank you so much, sir.
thank you.
So there is one more question in chat box here. Oral drugs and doses for endometriosis if not willing for surgery.
First of all, if you are not willing for the surgeries, think that you are giving the oral medications. Maybe a diagnosis is there, and the dydrogesterone. The dydrogesterone is the drug which comes with the endometriosis. That what the dufostan is the original maker of the dydrogesterone. That comes for the endometriosis. But saying so, whenever it is been done, you need to understand what is the reproductive potential of the patient. If you are giving the patient the dinogestrone or maybe a dydrogesterone, if the patient is having a minimal disease and the good ovarian reserve, then better to give it rather than giving it in a just an empirical way where the potential of the patient is AMH 1.5 and you are giving a dydrogesterone or digest, and for 6 months then that AMH and AFC will go down, and then you will go with the donor program.
So very judicial, a very limited use of oral drugs in infertility cases with the endometriosis. So fertility comes prior to the any other suppressive medicines.
Use of
Okay,
both
let us.
surgery and the medicine are very important, sir.
Yes,
Use of both things.
absolutely.
And one
Because majority of you are doing both, so an excellent surgeons, and I really appreciate the way of surgeries now the people are doing. I appreciate them, but the surgery will not be the key,
Yes,
because
sir.
we need to understand. I know now bowel vessel handling and bowel staplers are going ahead any of the surgeries, but mind well, it need to be assessed. It's not just a surgery will suffice. In certain situations, if you do a beautiful surgeries, they will not become pregnant. So you need to understand if you are doing the surgery, whether you are doing a 3D or maybe a harmonic or what it may be, ovarian tissue is going to damage whatsoever. So it's a judicious of both.
Uh, Thank you, sir.
Thank you. Thanks.
So we'll discuss further about role of endoscopic surgery in my talk.
Yeah, sure.
I think that
Yeah. So
Into next
Ma'am,
session.
someone has asked about dosing of oral drugs.
Dosing is a digest when you start is 4 milligram, 2 milligram BD, and when you are doing the dydrogesterone, it's a 10 milligram BD. So that is the dose. At least for 3 months you can give, and then you can continue. There are the studies of Dinoges being used for 90 days and more than that. So it's depending upon the situation of the patient.
Yeah, thank you, sir.
Thank you.
Chairperson. Shall I introduce the chairperson for next session?
Yes, ma'am.
yes, yes.
Next session is talk on role endometriosis surgery in infertility by Dr. Sejal Naik. Chairpersons for that are Dr. Sheetal Bhandari. She is the president of Society, and she was secretary of the Pusar Society, and she is director of Devashish Bhandari Hospital. And the other chairperson is Dr. Pranita Revanwar, who is the secretary of Pusar, the OBGY Society. So I will hand over the session to them to introduce the next speaker. Everyone can see in the screen. Sheetal madam.
I think she can we say Sheetal madam? She was in labor. She already told that she may be occupied if she is.
Pranita madam is there. Madam, you please
Okay.
introduce.
Yes, good evening, madam.
Welcome, madam. Thank you so much for joining, madam.
Thank you, madam.
Shall I start my screen sharing? One second. Okay. So can you see now?
Yes, madam, it is visible.
Yeah,
Yes,
yeah.
madam.
So without wasting much time, would like to start my today's talk, that is on role of fertility enhancing surgeries in endometriosis. So clinically, usually the patient presents with the pain. The pain can be dysmenorrhea, deep-seated pelvic pain, dyspareunia, dyschezia, maybe dysuria, or just maybe present with the depression and anxiety related to pain. And the other symptoms will be the abnormal uterine bleeding, diarrhea, constipation, or chronic fatigue, nausea, vomiting associated with pain, apart from the fertility aspects. So, sites of endometriosis can be various. Most common are the ovary, cul-de-sac, and the uterosacral ligaments. So, the association of fertility and the endometriosis has been established many decades, many years ago, many centuries ago. The endometriosis affects up to 10 to 15% of the reproductive women, and the most of the women with endometriosis have delay in average 7 years from the onset of symptoms till the diagnosis is being made. So definite cause relationship between the infertility and endometriosis is still to be established. The prevalence of that endometriosis is 25 to 50% in women with infertility, and 30 to 50% of the women with endometriosis have infertility. So fecundity rate reduces over a period of years. She is being untreated, left untreated. So there
Sejal,
is
1
always a
minute.
need.
Slides
Yeah,
are not
sorry.
moving, Sejal.
Oh, 1 second. Slides are not moving.
Yeah.
Now
Yeah.
this
How it's moving now? Yeah.
and make it full screen.
Yeah, it's full screen.
No,
Now
it's not full
No.
screen. No, it's not full screen.
it's moving.
Click on the slide. Click on the other slide. No, it's not moving.
Sejal,
And
read again.
share it again.
Okay.
Stop and share it again.
It's
Yeah,
moving,
yeah.
but it is
Okay,
not on
sorry.
full screen.
Yeah, sorry.
No problem, Sejal.
Hi,
Take your own time. Namaskar, Mohil Kumar. How are you?
Yeah, I'm fine, sir. How are you?
Absolutely fine. फरता फरता रूम पर पहुंची गया.
ના સર હું ઓપીડી માં જસ્ટ
હા, પણ ગાડીમાં હતા.
હા એટલે સર્જરી પતે નીકળું સર.
સરસ.
Uh, आजा, जल्दी आजा.
So, hello everyone. This is Dr. Sneha Buyar. Hi, Dr. Sejal.
Hello, madam. Hello.
Hello.
I'm just.
So, I joined as per your request, and I'm here for some time.
Thank you, madam. 1 second. I'm just finding my slide. Yeah.
Hello, Sneha.
Hi, Dr. Adulika. Hi. I can see everybody here. Hello, Manish sir.
નમસ્કાર, madam.
Namaskar, namaskar.
Good evening,
Yes.
Dr. Manish.
Good evening, madam.
I can see so many of my friends here from Pusad, Pranita
Can you
Revanwar.
see now?
Yes, yes, Sejal. Now put it on screen.
Is it moving?
No.
No. Just wait.
Yeah.
Screen is screen.
You make it slideshow, no? Say, click on the slideshow icon.
She is already, yes. Now, Sejal, go down and put on a full slideshow. Yes.
Yeah. Is it moving now?
No, ma'am.
No. Maybe some speed issue, Sejal.
Net is here full.
Hmm.
It's not in slideshow also. Say, You have to put it in slideshow first. Right side, no, you have a slideshow icon. You click on it.
Is it working now?
No, no.
Okay, I'll change my laptop then. If Neelam madam has joined, we can start with Neelam madam's talk. Because I can't see the you know.
Now, Sejal, your slide sorter has already seen. Put it in a slideshow mode.
Okay. If possible, I will. Is this way is okay?
Yes, yes. Now put on a slideshow. Third button.
But it's not like I am
Now
putting
it will work. It will work. It will work. Have patience. It will work. Just put out on a slideshow. No, no.
It's on slideshow now.
No, it's not on slideshow.
Okay,
You see the
so here
highlighted button is yes. Go on the last button.
It's showing here on slideshow, but it's
Now click
actually
that.
not.
Click it. Click it.
Click that. Yes.
You can present like this also, Dr. Sejal.
Okay, no, I'll do from the other.
Now, Sajal, it's okay. Just wait for a few seconds. Your slides are moving. Just you have to put it on a slide mode. And the picture in your laptop will be on 2 slides.
I'll share with the some other computer.
No problem.
Kindly, mute, no, volume बंद कर दो. Where is it? Okay.
Meanwhile, assistant is there.
No, हाँ sir. Battery charger. થોડું મોડું થાય છે ને. Okay, let it be. Leave it. આમાં ખોલી દે. એમાં જ ખોલી દે ને PPT. So પેલાને કહી દે ને કે મને શેર કરી. Zoom. Is it
Yes,
seen now?
Sajal. Fantastic. Now go
So
ahead.
yeah, sorry,
the best.
sorry for the delay. I'll do from this other laptop.
Uh,
So,
yeah.
okay. So where were we? Yeah, the symptoms we already discussed. Dysmenorrhea, deep-seated pain, and other abnormal uterine bleeding. The sites, as we say, the most common are the ovarian cul-de-sacs and the uterosacral ligaments. The infertility and the endometriosis association, as I said, has a very like complex association, and it has been described by many years, but still it is a controversial. It has been said that the prevalence of endometriosis is 25% to 50% in the women with infertility, and the 30 to 50% of the women of infertility, women with the endometriosis having the infertility. So they both goes hand by hand, and fecundability rate reduces as the years passes when the treatment is not being given on time. So there is always a dilemma when to do the laparoscopy, when to do directly ask for the IVF, or which are the patient who fits for the IUI. So endometriosis fertility index is one of those easy tool, or the a little bit objective tool to guide and to select the protocol for the endometriosis patient, where the apart from the surgical staging, apart from the level of disease, the age and other factor has also been included, and the estimated percentage is calculated about her like EFI score. And this EFI, according to the EFI score, the patients can be guided further how she can achieve the pregnancy at the earliest. Now, the what is the aim of these surgeries? Aim of the surgery is to conserve the reproductive function of the women, along with the minimum damage to the ovary and the other organs, with the maximum restoration of the anatomy as far as possible, and the maximum removal of the disease, so that there is a reduced risk of recurrence. What are the procedures? Surgical procedures can be simply excision of the endometriomas. There will be adhesolysis and restoration of anatomy, salpingo-ovariolisis, etc. The clearance of the pouch of Douglas, which reduces also the dyspareunia. Excision of the endometriotic nodules on the uterosacral ligaments, or the any other broad ligaments, or over the uterus. And the pain management can be of different modality. The colorectal involvement can be managed separately with the specialized skilled surgeons. The bladder endometriosis and the urethral or the urethral disease removal. Now, what are the principles? Are the pre-operative patient's assessment and the counseling is most important by the surgeon himself, because endometriosis may look very simple on the ultrasound, but can be very extensive. Adhesolysis is expected inside, and sometimes even the large endometrioma have a very little adhesions. So one has to assess the patient pre-operatively by ultrasound, by pervaginal examination, by rectal ultrasound or the perineal ultrasound to find out any extensive disease, and the proper counseling. Discipline in the surgeon, which is what is the aim, what why the surgery patient wants the surgery, and what is your skill and what you can give the best to the patient. So it if you feel like you are not yet enough competent, better to refer the patient to the good surgeon, because the first surgery usually gives the best outcome to the patient. And the discipline is unnecessarily, just you know that you can do these extensive like bowel anastomosis, etc. That doesn't mean that we keep on doing in each and every patient. So select the patient properly and follow their treat each patient as if your own relative. So excellent knowledge about the anatomy is must, because the anatomy is completely distorted there in majority of the cases of endometriosis. Knowledge about the equipment, how to use the energy sources and when to use, and which is the best tool for where, and their malfunction, especially intra surgical during intraoperative procedure. The limit equipments list in the OT, and limit the instrument lists on the table. Just avoid overcrowding, and just make the simpler use of the same tools for the different steps. thorough examination of the uterus and the adnexus and the pelvis before you start any procedure, and as soon as we enter the abdomen, and reconfirmation of the all preoperative diagnosis before proceeding to any steps. How the endometriosis spots can appear can be of dark black lesion. 80% are the white opacified lesion that can be red flame glandular lesion. Usually are like found in sub-ovarian areas, or there can be a endometrioma. Yellow brown patches can be there, and 13 to 15% are the microscopic lesions which are not seen on laparoscopy. So review says the in infertile patient, stage 1 and 2 endometriosis, clinician should perform the operative laparoscopy, excision or ablation that includes the adhesolysis rather than performing just a diagnostic scopy. Operative scopy obviously increase the ongoing pregnancy rates. Endometrioma of like that affects around 17 to 44% of the women in endometriosis, and 50% cases are usually having the bilateral endometriomas. The cyst aspiration alone can be done, but it is not recommended because it is not the curative treatment for the patient, and drainage and ablation of the cyst wall by laser or the by like excision of the cyst capsule by cystectomy is the preferred method, and the cystectomy is currently considered as a gold standard for therapy for the endometrioma for pain removal, pain like reduction in the pain, and the spontaneous conception rate over the 3 years has increased over to 50%. Anatomical orientation and restoration is the first step, where the all adhesions of the uterosacral ligaments and the pouch of Douglas has been released, and usually by doing so, the endometrioma cyst rupture, and then the chocolate material can be drained out from that the weakest point where it rupture. Once this anatomy is restoration done, identification of the ureter and the tube as a primary step, and the after the this correction, one can go ahead with the cystectomy. Cystectomy is performed with the edge is sharply cut, and two layers of the cyst wall are gently pulled and separated with each other with the three hands. One is holding the cyst wall and one holding the ovary, and with using the minimum of traction, not stretching and tearing them apart. Try to peel out very gently through from the ovary, where there is a minimum blood loss and the minimum net original like follicular damage to the normal ovarian cortex can be prevented. Hemostasis can be achieved by the just coagulating the final sputters over the cyst wall under the suction and irrigation, where you avoid coagulating the entire cyst wall, and just by simply the compressing the both wall together with the atraumatic grasper for the 5 minutes will reduce the further blood loss and can do the good approximation of the both edges without coagulating and damaging more without using the energy sources over the um, uh, uh, normal ovarian tissue that can not that will not reduce the ovarian reserve further. So wherever there is any injury or any suspicious of the injury on the rectum or adhesolysis, one can do check the intraoperative rectal injury by inflating the air or rectum under the water seal, and if the bubbles are not seen, then you can definitely be assured of having no injury, and that is to be checked intraoperatively rather than later on keeping these suspicions of bowel trauma or the rectal injuries later on. So that can reduce the morbidity of the patient if diagnosed intraoperatively. What the ASHRAE review says that the evidence B level of B infertile women, that level stage 3 and 4 endometriosis, clinician can consider operative surgery instead of expectant management to increase the pregnancy rate. And those undergoing surgery, clinician should perform the excision of the endometrioma capsule instead of just a drainage of the this capsule. That is the level A evidence to increase the pregnancy rate. The Cochrane study also support that the laparoscopic surgery to treat mild and moderate endometriosis will also reduce the oral pain and increase the live birth rate. The laparoscopic excision and ablation were similarly effective in relieving pain, where there was only one study. So, reduced ovarian reserve has always been questioned by the IVF consultant, especially. Okay, your laparoscopic surgery can reduce the ovarian concern, and it has also stated that statistically significant cystectomized ovaries have the then in the coagulated ovaries that reduces ovarian reserve, and IVF response and ovarian induction protocols or the drugs has been require more in the cystectomized patient. There was a study, infertility study 2011 with the ASRM, and they published the cystectomy, even though performed with an accurate surgical technique, leads to significant ovarian tissue removal. So thickness, which is more increased prophylactically with the more the thicker the cyst was, more the reduction in the ovarian reserve. But the Journal of Minimal Invasive Gynecology came up with that it is the singer, not the song. Means that it is the surgeon, not the actual. There's a cystectomy causes the more damage. The more they particularly excellent surgeon and they can do the very excellent surgery, have a very less reduction in the ovarian reserve. So overall quality of the surgery may have a major role in determining the damage of the ovary. It has been studied that the residents doctors, when they perform the surgery, are known to have the more reduction in the ovarian reserve than if it is done with the excellent surgeon. uh, Surgical treatment of ovarian endometrioma, where we state it is the benefit definitely favors the surgical approach, and however in case of recurrent endometriosis or already reduced ovarian reserve, the risk of repeated surgery should be taken into account, and one can restrain operating those patients again and again, especially in the patient where the fertility is a main concern. The more studies still we need to compare the excision and laser ablations or other combined modalities, and the use of GnRH agonist in such a cases of recurrent endometriosis. So, it is being a chronic inflammatory process. Endometriosis has a wide spectrum, and the overall recurrence rate between 6 to 67%, depending upon the which criteria we consider, whether it's a clinical endometriosis or the symptoms that has recurred. The reported recurrence rate for pain in 3 to 5 years are 20 and 43% respectively, and the recurrence rate for those clinical recurrence rate is around 9 to 28% over a period of 5 years respectively. So the 2 years recurrence rate in stage 1 and stage 2 endometriosis is 5 to 7%, and stage 3 and stage 4 is around 14%. Endotape or the undervision trocar can be used for this sort of kind of recurrent surgeries are being performed. And deep endometriosis here, I would like to skip, but the deep endometriosis nodules that who underwent surgery and those who are managed expectantly 24 months, the cumulative pregnancy rate was noted here. It was almost similar, but the morbidity is more with the operated cases. So these kind of patients are mainly operated for the pain relief. The recent study of 41 ICSI and IVF cycles, the female A serum AMH level and the number of previous cycles attempted were significant predictor of the clinical pregnancy rather than the surgical outcome. So focusing on the surgery results in infertile patient with deep endometriosis. Bowel endometriosis has a very negative effect and the high morbidity on the following the laparoscopic surgery, and even untreated having the poor quality of life. So surgery for grade 3 and 4 endometriosis here, where the anatomical restoration. Sorry, this video is not playing. Okay, let me see. somehow video is not playing. So, where again the bowel adhesolysis and the tubal anatomy restoration with the salpingo-ovariolisis has to be done. The unusual endometriotic site like the calcified endometrioma or the bladder endometriosis are also be kept in the mind, and that if required can be do the cystoscopy along with the this laparoscopic surgery, and can be confirmed and treated accordingly. So when to do IUI? Is there any place of IUI in endometriosis? In the stage 1 and 2 endometriosis, clinician may perform IUI with the control ovarian stimulation instead of expected management. And several studies reported the that with the gonadotrophins or super ovulation with the gonadotrophins, and IUI can be variable in options of stage 1 and 2 endometriosis alternatively, or before the IVF one can try when there is a very with the AMH value is good. So surgery prior to IVF, if it is unilateral endometrioma, does not affect the ovarian response to stimulation, one can uh, uh, do not need to perform the surgery. If hydrosalpinx is there, more than 2 centimeter, when associated with low pregnancy rate, even with the surgery, and then IVF herein is a promising solution because excuse me, can you mute? Can you mute other? Please mute yourself. So, uh, okay. So hydrosalpinx more than 2 centimeter have been associated with the low pregnancy rate and can be removed prior to the IVF because of the poor outcome of implantation rate. And the younger the patient and can be wait for 1 year if the good AMH and other factors are normal before IVF, and can be tried other treatment. If the patient's age is 35 years, should go IVF earlier. Maximum waiting period can be extended to up to 6 months. Early IVF is always better than the late IVF. Endometrioma of less than 3 centimeter, no evidence that the cystectomy is having a good better outcome. But endometrioma of more than 4 centimeter, to improve the endometriosis associated pain or difficulty during the oocyte retrieval, potential pelvic infection, other follicular fluid contamination can be managed with the preoperative surgery. That is the risk of reduction in the ovarian reserve after the surgery, and the possible loss of ovary is to be considered before going ahead with the surgery. The decision to proceed with the surgery should be considered carefully if the woman had previous ovarian surgery. So that is the ASHRAE good clinical practice guidelines. The fertility preservation techniques also includes that the oocyte preservation or the embryo freezing and the pooling of the embryos can be considered in the patients with the kind of repeated endometriosis. So infertility, this is a flow chart that suspected endometriosis. If she is an advanced reproductive age, if she is having pain, then go for the surgery. If she is not having pain and the advanced age, then she is directly advised for the better to go directly for the IART because of her advanced age or the other factor. If she's a young patient and having the good ovarian reserve, a normal fallopian tubes and normal partners parameter, and still having if pain, then one can go ahead with the laparoscopy. And then if she doesn't conceive after that, one can be think over the ART. But if she is not in pain and other factors are normal, good AMH, young age, then expectant management can be given, or the follicle ovulation induction or IUI can be given in such a patient as a other option. One can wait for the laparoscopic surgery. If that treatment modality fails, then can laparoscopy is the step, and the expected management following the laparoscopy or in the correction of the anatomy and removal of the disease is being done for 6 to 12 months. And if those within this expectant period of 6 to 12 months she won't conceive with the ovulation or IUI, then IVF is the choice. So point here to note that do not go on waiting many like much time in this kind of patients. So I conclude my talk here with the few carry home messages. That is, the endometriosis fertility index is the recent scoring system that correlates the disease severity and with the prognosis in terms of reproductive outcome. The biomarkers have no role in diagnosis of endometriosis. Recently, are coming up with a newer biomarker. Let's see how does they work. The medical management should not be given for the patient trying for conception. That will delay her time to conception, and the exception being the down regulation of ovary prior to the IVF. Laparoscopic surgery for mild endometriosis almost doubles the spontaneous pregnancy rate. In women with a moderate to severe endometriosis, operative laparoscopy increases the spontaneous pregnancy rate. We decide the surgery by the size of the endometrioma. If less than 4 centimeter, usually we do the observation, and excision of the ovarian endometrium larger than 4 centimeter increases the pregnancy rate and decreases the recurrence rate. But it has also the negative impact on the ovarian reserve and AMH. Surgery in expert hand might result increase in significant improvement, and the decrease in AMH may recover following a year of the surgery. But antral follicle count has no impact pre-operative or the post-operative measurements. The endometrioma of less than 3 centimeters, as I said, we do not try to touch until unless she is not in pain. If more than 3 centimeter protein and the patient is for IVF, then only to remove when if she is having pain or it is difficulty in assessing the follicles during the oocyte retrieval. So IUI has a very limited role in endometriosis, maybe in mild endometriosis and a young patient. The place of IUI, like with the moderate and severe endometriosis and older women, one has to be very judicious with the restriction in the number of total cycle, and repeat surgery is associated with significant lower pregnancy rate. So one has to restrict themselves, and they offer the best first surgery so that the number of repeat surgery can be reduced. In patients who have failed the primary surgery, assisted reproduction appears to be significantly more effective than the repeat surgery. But in patient who failed assisted reproduction, the management remains still be very extremely controversial. The incidence of recurrence of the endometriosis is not increase after the control ovarian stimulation for IVF. So do not worry about it. And endometriosis is such a kind of complex surgery requires a great team. So teamwork can do dream work. And thank you so much. Thank you. And here I humbly request to kindly vote in support me for the FOGSI endoscopy committee chairperson. Thank you. Thank you for patience here.
Hello, madam.
Yes, madam.
Pranita.
Yes, madam. How are you, ma'am? Yes. Thank you, ma'am, joining.
फाईन मॅडम. मॅडम म्हणजे जेव्हा आम्ही सीझर करतो तेव्हा आपल्याला बरेचदा एंडोमेट्रोसिस पोस्टीरियर वॉल किंवा एंट्री वॉल वर दिसते. मग अशा वेळेस आपण काही पेशंटची हेल्प करायला पाहिजे का?
You mean कि जब laparoscopy we are doing the laparoscopy and you find there is a endometriotic spots.
नहीं, while doing LSCS, Caesar,
LSCS
or any laparotomy, when we see there is a endometriosis, then what we should do?
Actually, anything like that is not priorly consented or explained to the patient, and to operate something that is not like, we would like to avoid doing such things when the patient is not properly counseled and consented to do the additional procedure. Laparoscopy for infertility, usually we nowadays we do hardly do any diagnostic because ultrasound has helped us. So it is usually a therapeutic, or whenever there is in a doubt of having mild or minimal endometriosis, we already have explained that patient that if we find anything that is suggestive, that is hindering to your pregnancy and fertility, then we will cure that. So in those cases, you can definitely do the coagulation of the superficial endometrial implants. We can do adhesolysis and we can restore the anatomy. But doing cesarean, what we have find sometimes there is a edema and the blood structure. There is some abrasion area over the like posterior surface of the uterus, which is commonly seen in many. If you regularly see the posterior aspect of the uterus in all cesarean cases, you will find it really very common, which usually regress over a period of time once the pregnancy edema has been reduced. So, and hyperemia has been reduced once the blood flow of the uterus has been reduced. So, we do not do anything. If she is the known case of endometrioma or the chocolate cyst before the pregnancy, and or during the pregnancy she is diagnosed, and if she asks for to removal of that chocolate cyst during the LSCS, so that is to be counseled and consented prior hand. It should never be on table.
Okay, thank you, madam.
That is my practice. I do never do anything that is very like, until and unless it is life threatening, life saving procedure. I do not do any plans that can be planned later on. So if it is there, sometimes we find a small fibroid or something. We just explain to patient it is there, it's a chocolate cyst or it is adhesion, or it is there, and we'll do later on.
Thank you, madam.
So what is others' opinion here? So accidental finding during any other surgery.
Ma'am, what I usually prefer to do is we are taking prior consent if there is endometriosis or not. See, abdomen is a magic box. When you are going to open, you will find out there is a spots-like structure over the uterosacral or something somewhere else. So we are taking the prior consent. If we find something like this in a diagnostic, we will gonna remove that. So that should be the good idea for the patient.
Yeah.
Very nice talk, Sejal. Good evening, everyone.
Thank you, madam.
And
Thank you so
my
much.
opinion
Thank
is
you.
same as yours, that if there is no prior consent, it should not be done. And if it was there earlier, then with consent we can do, especially for endometrioma. Not for endometriosis, it should not be done during cesarean. Yeah.
Thank you, ma'am. Thank you so much, ma'am, for joining. And
Yeah.
we are looking forward to your talk on fibroids.
Yeah.
So
So
we can move
should I
ahead with
share
the
my
next.
screen? Yeah.
Yeah.
So can I
Please
have,
introduce, ma'am, 1 minute.
yeah.
Please kindly introduce a chairperson.
I am disabled in screen sharing, so please
So,
ask
yeah,
your
ma'am, we are.
Good evening, Dr. Neelam, ma'am.
Yeah, good evening, Madhulika.
Nice to see you.
Yeah, yes. We are living in the same city, but seeing each other on video. That's good.
So our next speaker for the session, third is Dr. Neela Modi. She is a chairperson of ISAR, UP and Varanasi Menopausal Society Vice President. Her lecture is on fibroid and infertility. The chairpersons are Dr. Vinod Agarwal. She's a clinical director of FIRST IVF, consultant laparoscopic surgeon and IVF specialist. He's a consultant of Brahmananda Narayana Multi-Speciality Hospital, Jamshedpur, and ex-consultant at Tata Motors Hospital, Jamshedpur, and uh, founder member of and the treasurer of the Jharkhand chapter of ISA, and established first IVF center in Jamshedpur. Our next chairperson is Dr. Sarita Kumari. She is the secretary of the Jamshedpur Society, and I would like to hand over to Dr. Neelam ma'am.
Yeah.
Ma'am, we are privileged that you are going to take a lecture on this.
Please make Neelam ma'am co-host.
Yeah, madam is co-host.
You
You
are
can inform.
co-host. Yes, ma'am.
Is my screen visible there?
No, ma'am.
No. Oh, okay. Screen system. Okay. There will be a problem now. What should I do? I don't know how to share. Let me, I tried to share, but it is not. आओ मेरी स्क्रीन शेयर कर दो जरा आओ जल्दी आओ
Madam, on your laptop, there is a share button.
yeah I did that but let me join again. It is not visible at present.
Okay, just log out and join again on the Zoom platform and try to share it.
Manish sir, and let us discuss more about the endometriosis and infertility. What is your take on for the drugs, like medical management?
Madam, there is a very tug of war between medicine management and laparoscopic surgeon. If suppose I am a gynecologist and you are a laparoscopic surgeon, then you will say that would like to do laparoscopy because in your presentation, as you mentioned, that
So we are
first
both.
laparoscopy,
We are
first
both.
laparoscopy on a good laparoscopy should be done at very good place. So there is a very big role. But whenever a situation comes when there is only less than 5 centimeter endometrioma, the patient is adolescent or patient wants to be on reproductive age group. Now there are very good options as the drugs available. Now let's talk about the 2D drugs. One is Dinogest and one is dydrogesterone. Okay. So Dinogest you can use in the patient those who don't want reproductive carrier. Okay. But if you want, if the patient wants to conceive during your infertility treatment, then 30 milligram dydrogesterone is also good option. And you can continue as a progesterone treatment for long. And if patient conceives, meanwhile, you can also continue this medication in first trimester. Okay. What is your take on? Which drug would you like to use, Sejal? Dinogest or dydrogesterone?
For infertility.
Yes, madam.
Madam, we can
Now
see
it
your...
has worked.
Sir,
Congratulations, madam.
I prefer dydrogesterone.
Yes, thank you. Because the dydrogesterone was
you
introduced
are
in India
absolutely
as a
right. If
meteoric drug.
patient doesn't want pregnancy, then it's all right. Dydrogest you can give. But,
yes, madam.
But for the fertility point of view, I think dydrogesterone is very good. It has
And
got
it
good
gives,
Neelam ma'am,
it
we
gives
can
the
see
same
your
purpose.
screen. We can see your screen, Neelam
Yes,
ma'am.
madam. All the best with fibroids.
Yeah. So,
Okay.
very good evening to all of you. It's really nice to be here. And I thank Dr. Sejal for inviting me for this very important talk, which I like from the core of my heart also, that is fibroids and infertility. So we know that the fibroids are the commonest benign tumors of the reproductive age group. But fibroids as a sole factor for infertility are found in the less than 10% of the infertile patients. And their relationship with infertility have always intrigued us, and it is really controversial and always a great concern for us and as well as for the patient also, that whether it should be operated, whether it should be treated or not. So many things are there. Here you can see that this fibroid is quite adjacent to the endometrium. So we know that it is going to impact the fertility, especially if we are going for the IVF or IUI procedure. But here you can say the endometrium is a bit away, means 1 to 2 centimeter away from the fibroid. So here lies the concern whether it will impact fertility or not. So today I will be talking about that do fibroids impact fertility? What is the mechanism to cause infertility in very short? And what is the best modality to diagnose? Which fibroids to be removed for fertility? Is there any role for the medical treatment? If we are going for the surgical treatment, then what surgery, in what cases, what precautions, and what results we expect after the myomectomy. So firstly, we know that there are different classifications like ESG and FIGO. We mostly follow FIGO classification. And regarding fertility, we know that the submucous fibroids and intramural fibroids encroaching the endometrium, they affect implantation and diminish pregnancy rates. These are from 0 to 3 number FIGO, 0 to 3 fibroids. And we also know that the subserosal fibroids, they don't have any effect on fertility prognosis. But the controversy lies here, that is intramural fibroids and also the subserous fibroids which have more than 50% of their part intramural. So here we have to decide whether we have to treat this fibroid, to take out this fibroid or not. So we will focus more on the intramural fibroids and their likelihood of achieving pregnancy. So in very short, you can see here there are a lot of factors which affect fibroids, hamper fertility, like implantation factor, alteration in the uterine contraction, that is really very important. Then formation of the pseudo capsule that is rich in the neurotransmitters and neurovascularization is there. Some genetic component is also there, like reduced expressions of FOGSI 10, FOGSI 11, and BT-B1. And there's physical impedance to the sperm and eggs by cavity distortion. Then there is alteration of endometrial myometrial zone. So these are various mechanisms cited for the effect of fibroids on fertility. So there are so many evidence related to intramural fibroids. First, let us see if there are intramural fibroids not distorting the cavity. So what evidence says? So this is a very often cited study, systematic review and meta-analysis by Sunkara et al. And there were 19 observational studies comprising of 6,087 IVF cycles, and they showed that the presence of non-cavity distorting intramural fibroids is associated with adverse pregnancy outcomes in women undergoing IVF treatment. Then there's another study of 2018, and this is meta-analysis of 9,189 IVF cycles. And it suggests that the presence of non-cavity distorting intramural fibroids significantly reduce the implantation rate, clinical pregnancy rates, live birth rates, and also significantly increase the miscarriage rates. Then this is another study of 2020 with 15 studies with 5,029 patients. And they revealed that there are lower odds of live births and lower odds of clinical pregnancy rates. So by so much large data, it is proved that the intramural fibroids also, which are not distorting the cavity, they affect the fertility. But what is the size? What should be the number? So this is a study of observational study though, of 2016, says that the fibroids, more than 2 fibroids and fibroids of more than 3 centimeter in diameter, they have deleterious effect on the live births. So conversely, in women with single fibroid of less than 3 centimeter, no difference in pregnancy outcome was identified. So yeah. Now coming to the fibroids which abut endometrium. So here you can see that this fibroid is quite close to the endometrium, and one ultrasound, this picture, it is abutting the endometrium. So these types of fibroids are a transition between submucosal and intramural fibroids. They, for all the practical purposes, they behave in terms of fertility, they behave as submucosal fibroids. And even the size is more than 2 centimeter or 2 centimeter, then even then they may have deleterious effect. And one study said that if the size is more than 3 centimeter, then they might exert deleterious effect. So this is regarding intramural fibroids abutting the endometrium. And what to say about intracavity fibroids? They said it is known that they negatively impact the fertility and negatively impact assisted reproductive outcomes, and they disrupt implantation by 33 to 70% and decrease clinical pregnancy rate up to 67%. So the question arises here, which myoma need to be removed? So what matters more? So here, by these studies, we can come to know that if the size is more than 3 centimeter, number is more than 2, and geography of lesion, especially submucous or abutting the endometrium, or distorting the cavity, or causing junctional zones derangement, or if it is symptomatic, like menorrhagia or pressure symptoms, then we have to remove it or treat it. Now coming to the diagnostic evaluation. So we know that the clinical examination, nobody can skip or should skip or must not skip. So enlarged mobile uterus with irregular contour. Ultrasound is the gold standard to diagnose the fibroids. And if there's a submucous component, then 3D ultrasound and sonohistography is the modality of choice. Now, with the advent of so much sophisticated machines, you cannot miss even a small intracavitary fibroid. So nowadays, we are not doing sonohistography. The 3D ultrasound tells us a lot. So you can see here in this above picture, you cannot know whether this is a fibroid or what is there in the cavity. And as soon as you switch to 3D, you will come to know that it is a small submucous myoma. And in case of the multiple fibroids, when you are not getting full access to the uterus, then MRI can come to your rescue, and it is supposed to be the most accurate modality to assess the adnexy and the uterus, and it helps in the fibroid mapping for the surgery, for knowing the size, location, and number of the fibroids. And nowadays, hysteroscopy remains the most accurate method, especially to treat the fibroid rather than to diagnose, but you can diagnose and treat at the same time, and CT is of limited value. Now coming to the management options, there. So broadly, we have 3 management options: medical option, surgical option, and the non-surgical options like uterine artery embolization and fibroid ablation. But for fertility patients, infertility patient, we don't go for these uterine artery embolization. So let us come to the medical treatment first. And now the question comes, as we heard that in endometriosis, medical treatment does not hold a place, means a very important place, except in some limited situation. So same is there in fibroids. And so though there are many products for the treatment of fibroids, like ulipristal, GnRH agonist, aromatase inhibitors, mifepristone, cabergoline, dinogex, so many of that are there. But its use is limited only in few select cases, like in previous myomectomy to avoid another surgery, or if there's very small fibroid closer to junctional zone, or if there's very small intramural fibroids abutting the cavity. So in these cases, you may take help of medical treatment 2 to 3 months before going for IVF. So here I want to quote this study, a retrospective study of 52 patients, and with ulipristal acetate treatment for the uterine fibroids in infertile patients. And of these, 18 pregnancies happened, 12 were by a spontaneous manner, and 6 by IVF. So there is a little role of medical treatment in fibroids with infertility. And this modality is GnRH agonist. So we can give in some select cases when there is a anemia to boost hemoglobin and to take some time before surgery, and it may reduce the volume of the fibroid as well. And we usually use this in cases of additional associated adenomyosis if it is there. This video is not working, but here is the fibroid along with adenomyosis. So with this GnRH agonist, no operative benefits have been found, and it should be used with caution for operative benefit because it makes the fibroid technically difficult to operate with distorted cleavage planes. So this is about the ulipristal and GnRH agonist before as medical treatment in cases of infertility. Now coming to the surgical management, and if we are going for the surgical management, then especially to enhance the fertility, a correct indication must be there before embarking on the surgery. So this is a hysteroscopy for submucosal fibroids, and here you can see that this hysteroscopy, this is the gold standard for submucous fibroids, and under normal saline, this resectoscope is inserted, and the movement is from the back to front, not the otherwise you may perforate the uterus, and very nicely the chips are coming out, and slowly you can complete the procedure. So, and many times when you take out all of the submucous fibroids, some part you may feel that is left behind in the intramural part. So you can stop the procedure for a while, come out and stop the saline. And after 5 minutes, when you will reintroduce this resectoscope and saline, then that myoma will pop inside the cavity and you can very safely remove that. Then there nowadays a hysteroscopic morcellator is also available, and by this you can chop off the fibroids, but the problem is that it usually takes care of the cavity part. The intramural part is not very well tackled with this. So this is a new addition in our armamentarium, the hysteroscopic morcellator. Now coming to laparoscopic mammectomy, and as I said that a clear indication should be there why you are taking out that particular fibroid, then according to size and position of the fibroid, you will make the ports. And here you can see there's a small fibroid, especially in the posterior wall and near the cervical, near the cervix, and this ovary was coming in the field again and again. So, and we did not want to manipulate from the uterus from inside. So we hung the ovary in the abdominal wall, and then we started the procedure and took out this fibroid. And incision was made horizontally for ease of the suturing of the fibroid. So you can see here that this fibroid is coming out, and as we know that every fibroid should be removed with the endobag morcellation. So this endobag is being introduced inside to take out the fibroid and morcellate inside the bag. This is a fibroid, a fundal fibroid, fundoposterior fibroid. And here I wanted to show wanted in this video to show you that during this fibroid removal, inadvertently, here you can see the endometrium is opened. So in infertile patient, if you open the endometrium inadvertently, then it is not a disaster and it should not be considered as a blunder, and you stitch nicely the cavity and taking as less as possible the endometrial part, then there will be no effect on the future fertility. So this is about the surgical techniques, and with all the fibroid, there's always a concern of the excess blood loss. So various techniques you can resort to, like GnRH analog before the operation, or vasoconstrictor agents. We use very frequently this vasopressin or temporary ligation of the uterine artery with ligation clip or coagulation can be done. So we